Next up we have a person I'm very honored to be able to present to you today, and that's Dr. David Lazar. David is a surgeon and a graduate of the residency program at UC San Diego, where I first met him. And when I first met David, it was pretty obvious that he was an exceptional individual, very committed, very warm and personable, and somebody who had that focus you knew was going to take him somewhere. And I was not too surprised when he decided that, told us he was going to become a pediatric surgeon. And we're very delighted he's come back to San Diego to become an attending at Rady's Children's Hospital, as also as UCSD faculty as well. So children are not small adults. We all know this, and it's very rare that anybody who does trauma care can ever say that there's no possibility ever meeting a injured child. We either have a backup capability, or somebody could always walk through the doors of the ED with an injured child, or there could be a disaster, and all those designations that we're so proud of go out the window. And so David's going to talk to you a bit about how to look after the injured child.
Dr. Doucette, thank you very much for that warm introduction. Okay, so my name is David Lazar. I'm a pediatric surgeon at Rady Children's. It's an honor to be here today. Just a quick show of hands. Who practices at a predominantly adult hospital? Hands up. Okay. All right, hands down. Who practices predominantly at a pediatric hospital? Nice to see you over there. Nice to see you. Okay, great. Perfect. So there's a lot to cover on this topic. I think my objective is really to try to provide some information that may make you guys a little bit more comfortable when the next kid rolls into your trauma bay. So I have no financial disclosures, but I do have a content disclosure, which is 99% of what I know about trauma I learned in my adult training, thanks to Dr. Doucette and his partners, and the remaining 1% is part of what I'll talk about today. So these are the objectives. I'm just going to kind of go quickly because it's a lot of stuff in a short period of time. I think there's a significant fear of the pediatric patient in the adult trauma bay. I don't know if you guys feel this. I certainly felt this as an adult general surgery resident. The kid rolls in and everyone's afraid to touch the kid. They're going to break the child, or the kid's screaming and they don't want to do anything wrong. So there's a genuine fear, and this is sort of the looks on the faces of the people in the trauma bay. People are worried that they're going to break the child, that the kids are really fragile, or they start crying immediately, and you're worried that they're injured and you're going to hurt them more. Other concerns I had before I trained in pediatric surgery is what medications can I give to a child, what doses, am I going to do harm? Obviously our first goal is to do no harm, and then what tests do we order? Am I going to miss an injury? Am I going to irradiate a child with 80 years of life left that didn't need a CT scan? So hopefully I can sort of put to rest some of these fears. And I would say, fortunately, although Dr. Doucette said the phrase we use all the time in pediatrics, that kids are not small adults, the truth is most of the anatomy and physiology is the same, and I'm just going to highlight a few differences. So let's start with the case. So let's say Johnny is peds versus auto victim at 20 miles an hour. You get the report from the EMTs that there was a loss of consciousness at the scene. Johnny has a parietal cephalic hematoma. Vitals are normal. They place a C-collar and a peripheral in the field. So what do you want to do first? Thank them for the peripheral IV. I heard airway, so maybe start with a primary survey. And I'm going to submit that it's the same for a 3-year-old as a 23-year-old. And I kind of already mentioned that. So let's take 2 trauma patients. Johnny is a 23-year-old adult trauma patient, and then Johnny, part 2 on the right, is a 3-year-old trauma patient, right? So, what would you do for your primary survey in an adult? Right, so you start with airway. So you ask their name, kind of go from there. For breathing, auscultate, palpate a radial pulse typically in an adult, have them move their extremities, assess their GCS, and then control their environment and expose them. In the kids, it's pretty much the same. There's some subtle differences. They may not be able to answer if you ask their name, either because they're not capable of responding due to their age, or they're intimidated by their environment. So you may just want to observe them. And they may start talking if you give them a few seconds, or crying. Both demonstrate a patent airway. You may want to stimulate them or pinch them. Figure out a way to prove to yourself that their airway is intact. And just like ATLS teaches us, you don't really want to move past A if you haven't already addressed A. So I try to give it some time in the trauma bay. Auscultate is the same. I was trained that the best place to auscultate is sort of in the axilla. The chest wall is the thinnest there. I agree with that in a child as well. Typically in pediatrics, we palpate a brachial pulse. A radial pulse can be a little faint in kids, especially in the hustle and bustle of the trauma base. So going for a brachial pulse is your best bet. And then for disability, they may not follow commands and be able to move their extremities, but you can watch them or you can stimulate them. And then, of course, assessing their GCS exposure is very similar. The secondary survey is pretty much the same. I think one notable exception is we do a lot fewer rectal exams in kids. We did it pretty universally in adults. It's probably not that necessary. You can look for gluteal tone or evidence of motor function down there. So here are some of the differences I'll highlight for the primary survey. Kids tend to have bigger heads, which results in more neck flexion. A lot of the time that can obstruct an airway. Ways to help is to put a blanket or a towel under the kid's chest and then lifting their chest up, allowing their head to fall backwards, trying to avoid things like pillows. Their oropharyngeal tissues are relatively larger than in adults, so you want to be mindful of that. Their vocal cords tend to be more anterior, so if you have to establish an endotracheal airway, just keep that in mind. You may need more cricoid, or you may need to really crank up on your laryngoscopy blade. And then as a general rule of thumb, ET tube size is 4+4. For breathing, the key thing to know is that kids are much more sensitive to hypoxia, and it's the most common cause of cardiac arrest in the trauma bay for children, unlike hypovolemia in adults. So just keep that in mind. You really have to focus on these kids breathing. They have a much smaller reserve. And then circulation, vital signs vary with age. Hopefully the EMTs will sort of give you a report and tell you where the kid is on the Breslow scale, and then you can know appropriately what the vital signs are, what the appropriate doses of medications are, et cetera, et cetera. As a general guideline, minimal systolic blood pressure that's acceptable is 70 plus age times 2. So a 5-year-old would be about a systolic of 80. And then disability. So GCS is different for infants. For most children, it's the same if they can follow commands, but for infants, it's a little bit different. The eye exam is the exact same, but they may not be able to give you a motor response and follow commands, so you just look for normal movements. Otherwise, their reactions to pain are the same. And then as far as verbal, they may not be able to talk, but they can coo or babble, and that's showing an appropriate verbal response. If they're crying in the trauma bay, that's a point off of the GCS, but for most of our algorithms, 15 is the same as 14. Okay, so let's take them. So you do your primary and your secondary and find that, in fact, he did have a loss of consciousness. He has a parietal septal hematoma. His GCS on your exam is 15, and he has scattered abrasions. So what are we going to do? How are we going to work this patient up? Do these patients both need imaging? Do they both need labs? So my argument is that this 3-year-old trauma patient doesn't need either imaging or labs. You can make an argument that labs may be relevant. So I'm going to delve in a little bit about this, and especially traumatic brain injury in kids. Trauma is the leading cause of death in kids who are over a year of age. TBI, it's the leading cause of trauma death, and it results in a large volume of patients, specifically 600,000 ED visits. Now, interestingly, at least prior to 2010, where sort of a seminal paper came out, 50% of these kids were getting CT scans of their head. And so that results in 300 CT scans of the head per year in the pediatric population. So when you see that number, I think you can be in sort of one of two audiences. You can be in the liberal use of CT for diagnosis audience, and you can be very excited and applaud this and say, oh, we're doing such a great job at screening. Or you can be like me and be a conservative and be absolutely horrified that we're irradiating so many kids' little heads and brains. And so I'll talk a little bit more about this. The benefit is you can pick up on unrecognized TBI as far as using a CT scan. And then kids who are pre-verbal or nonverbal or refuse to be verbal, it's a good way to evaluate them. Against the liberal use of CT scan, it's low yield. Less than 10% of kids who are undergoing a CT of the head are found to have a traumatic brain injury. Most centers require transport outside the ED, although it's becoming more popular to have CT scanners in your ED or adjacent to your trauma bay. Obviously, this puts children at risk, especially if airway and breathing are of concern. Many children need sedation to acquire images, to sit still. So now we're putting a kid at risk by sedating them outside of the trauma bay and in the CT scanner in order to acquire images that may not contribute to their management. It can come at a significant cost to both the family and the healthcare system, and there's risk of associated radiation. So just to touch on that a little bit, so the lifetime risk of cancer is significantly higher in a child who's exposed to radiation. There are two main reasons. One is kids live longer, so the radiation you may expose a 40-year-old to, they only have to deal with changes from that radiation for another 40 years, but a 2-year-old will have to deal with it for another 80 years of cell division, metabolism, things like that. And kids have a higher metabolism, and they have rapidly dividing tissues, which puts them at risk and being more susceptible to radiation-induced change. So if this is based on actually atomic bomb data out of World War II, and then there's other data that sort of corroborate this as far as associations, but it's thought to be that the lifetime risk of cancer death due to a CT head in a 1-year-old is 1 in 1,500. So that's not a small number. And in a 10-year-old is 1 in 5,000. And when you go back and you think about how many annual head CTs we're doing per year, that could be a lot of cancer deaths when they all add up. So the question is how to find a balance, how to make sure that you're not missing injuries, but at the same time you're not over scanning. And it's easy to do if a patient comes in and they have an altered GCS or they have a blown pupil. I mean, that's simple, right? You scan that patient no matter what their age is. But it's a little more difficult to do in minor head trauma, where maybe they had a loss of consciousness, or maybe they present with cephalohematoma, or maybe their GCS is just mildly depressed. So a very good emergency medicine study was conducted across multiple institutions in North America called the PECARN study, and it aimed to answer this question. I'll flip through this really quick, but they basically defined what it means to have a clinically important TBI. So if a patient has a head bleed, but it never affects them and you wouldn't otherwise have known it and they can live their life normally, then does it really matter that we know that it's there? And so the way they defined this was death from a TBI that resulted in neurosurgical procedure, intubation, or a prolonged hospitalization. And so they had essentially 42,000 patients that they analyzed. They had 4/5 of those patients were in the experimental group and 1/5 in the validation group. And they looked at a tremendous number of variables and they divided it up between mostly the verbal and the pre-verbal kids. And I'm just going to go through the algorithms real quick. So basically in a kid less than 2, an infant, if they had any signs of altered mental status or depressed GCS or a palpable skull fracture, then you got a CT. The chance of having a clinically significant brain injury is not small, it's 4 to 5%. If they don't have any of that stuff, if they're acting pretty normally, but they have cephalohematoma, a prolonged LOC longer than 5 seconds, a severe mechanism of injury, or the parent says they're not acting normal, then you have choices, you have options. And it can be based on your hospital system, your personal comfort as a provider, the family's tendencies, and you can either decide to observe the kid and not CT them because, that's if they don't have any of those. The risk of TBI is almost 0. But if they do have those, then there's a less than 1% risk of a clinically significant traumatic brain injury. And you can either observe those kids or CT them. In our institution, we predominantly observe those kids. Same thing for older children. If they're altered, you scan them. If they're not altered and they've had LOC or they've had vomiting or they have a severe mechanism or an ongoing headache, if they don't, you don't have to do anything. But if they do have that, their risk of a clinically significant TBI is still less than 1%, and you can observe them. And that, of course, is based on your comfort level, the parent's comfort level, et cetera, et cetera. This has sort of been validated. The sensitivity and negative predictive values are very high. And there have been multiple studies looking at different aspects of this data set, including comparing it to data in Europe, and it's very consistent. So for Johnny, who had a positive loss of consciousness, a cephalohematoma, abrasions, the 23-year-old Johnny may get a head CT, may get a CT of his C-spine, may get either a fast or an abdominal CT, may get a chest film, may get a pelvic film, may get labs. I don't know if I'm off about this. Would everybody agree with that? That's what happens in their trauma center, but we don't want to subject a kid to all that stuff, right? Especially based on the data that I've already presented. So do we need to CT this kid? I would argue we don't. And then I was going to go to this really quick if it pulls up and show you that you don't need to remember all these algorithms. You can just, it won't go. You can just Google PECARN calculator and just click on boxes and it'll tell you whether to scan the kid or not. And it's an absolutely amazing tool. It's validated. It's medically, legally legit. So I'd recommend that everybody take a look at that at some point. Pull it up on your phone, take a look. PECARN calculator. Okay, so no head CT. We've decided that for Johnny. What about evaluating his C-spine? Let's see how we are on time. Oh, okay. Okay, so it's pretty rare for kids to have a C-spine injury. Only in severe blunt trauma do kids have a real likelihood of that. And most of the time, the kids look like this, right? They're super cute. At least that's what you picture when you put a C-collar on. They're happy, they're smiling, they can sit up. But really, it ends up like this guy. Lying in bed, it's upside down, it's covering his face, it's flexing his neck. We've all seen that. And this is what happens with kids because the C-collars, even the children's ones, aren't great fits. They have short necks, very anterior airways, big heads, all that stuff we talked about. Kids who are less than 8 are actually susceptible to more upper C-spine injuries, unlike adults who sort of had mid or lower C-spine injuries. That's because their heads are larger, which creates a fulcrum higher up, and their vertebral ligaments are much more flexible, so they end up with subluxation. So same arguments for the liberal use of a CT for it to evaluate the C-spine. You know, you don't want to miss anything. A lot of these kids won't talk to you, so how do you figure it out otherwise? But again, the same argument is against that as for head CT, which is it comes at a cost to the system as well as risk of radiation. CT scans of the C-spine essentially generate 10 to 14 times more radiation exposure than a plain film. And that's the important structures really in the neck or the skin and the thyroid that are susceptible to radiation-induced malignancies. Same reasons why why radiation has more of an effect on kids. They live longer, have higher metabolism. Remember the lifetime risks of cancer. They're pretty much the same for the neck as they are for the head. So I'm going to put forth this statement that most children do not need radiographic evaluation in the trauma bay. And this to me, when I went into pediatric surgery training, was really bizarre. This was like blasphemy. Like, how could we not scan a C-spine? Like we're going to miss something, and the kid's going to be paralyzed, and everyone's going to get sued, and that's just not the case. Children, I'd make the argument that it's a population of adults, but I'm going to focus on children, can be cleared clinically and avoid exposure to radiation. And the Nexus trial or trials have supported this in large numbers. And so if they meet this criteria, they have no midline tenderness, they have no focal deficit, they're alert, they can respond to you, they're not intoxicated, which fortunately most kids aren't, and they have no distracting injuries, then you can make an attempt to clear them clinically. And this was the result of a patient cohort that was 3,000 kids large, 1% of them had C-spine injuries, and it was very sensitive and had a great negative predictive value. This is the C-spine clearance protocol we have at Children's and at a lot of freestanding children's hospitals. It's very, very similar. I don't know how much of this projects, but basically, if the kid meets the Nexus criteria, they can be cleared by exam. And if their exam is negative, then the collar can be removed, you're done, no imaging. If they either don't meet criteria or you cannot clear them clinically, then we get a lateral C-spine film. A single lateral C-spine film in the trauma bay. If that film is normal, then you give them some time, you reassess them, you try to clear them again. If they can't be cleared a second time, we send them home from the trauma bay with a C-collar. The chance of them having a clinically significant C-spine injury is still very, very low. We send them home with a C-collar. We do not scan them, but they have orthopedic or spine follow-up. If their lateral C-spine film is abnormal, then that generates a scan and a spine consult. So again, for Johnny, CT head, CT C-spine, CT abdomen pelvis versus fast, chest X-ray, pelvis X-ray, labs, and then little Johnny, we're going to do no head CT and no CT of the C-spine. We're going to try to clear him clinically. I'm going to touch very quickly on solid organ injury. And basically, the need for imaging of solid organs, particularly in the abdomen, in children is based on, sorry, I'm on call, is based on labs and exam. If a patient has a normal exam and normal labs, they don't need radiographic evaluation of their abdomen. If they have an abnormal exam or they have abnormal labs, and particularly that's an AST, ALT, and a lipase, or an abnormal hemoglobin, then CT is the gold standard for kids. Having grown up in the Hillcrest model, I'm a big believer in FAST, but FAST just really hasn't been validated in the kids. The kids are different sizes, so there's different volumes of blood or fluid that would make a FAST positive in a kid, and ultrasound technology just isn't there yet to be specific enough to pick up on a small amount of fluid that would be reflective of a solid organ injury in a kid. There are some papers that are coming out about giving IV contrast that would help make a FAST more sensitive and or specific in children, and several centers are studying this. And then, of course, probably, I don't know, I guess 30 or 40 years ago, we used to take splenic injuries to the OR pretty consistently, but now we've learned that most of those patients can be just observed and or transfused without the need for operative intervention, and this predominantly came out of the pediatric literature where we want to try to preserve children's organs when possible. This is one of the better papers out about when to CT the abdomen of a patient, and this is out of South Carolina, but it was a multi-center study at 14 institutions, and basically these are all based on 5 criteria that you can assess in the trauma bay, and you can assess essentially within an hour or so. The first is a complaint of abdominal pain, so if a kid has abdominal pain, then they're at a 27.5% chance of having intra-abdominal injury, but a 6% chance of one that needs intervention. And then you can sort of go down the list. So if they're complaining about abdominal pain, if they have finding on abdominal exam, so tenderness, distension, seatbelt sign, that generates a scan. If they have abnormal chest x-ray, that would generate a scan. If they have abnormal LFTs, particularly greater than 200, that's from a paper that came out of CHOP. Some centers do 3 times the upper limit of normal, then they don't need a scan. But if their AST or LFT is just mildly elevated, you don't need to reflexively scan these kids. And if they have an abnormal lipase, you scan these kids. If they don't have any of those findings, the chance of them having a clinically significant injury is 0.0%. So when you see a kid, think about these 5 things: abdominal pain, abdominal exam, X-ray, LFTs, lipase. Those are all normal. They don't need abdominal imaging. I'm going to touch very quickly on NAT or non-accidental trauma, child abuse. We see it very commonly, and it's something to think about. Always, I would say, always have it in the back of your mind when you're dealing with a pediatric trauma patient. Here's some of the epidemiology. There's a lot of victims per year when you lump it in with neglect. Fewer kids that are less than 3 make up the minority of cases, but the majority of deaths. Most of the deaths sadly involve a parent or both parents. And 10 to 11% of trauma, generally speaking, is a result of NAT, so be aware. It's a challenging diagnosis to make. Patients are often unable to provide a history, whether they're too young or intimidated by their parents or scared or hurt. Exam findings can be very subtle, and injury patterns, although suggestive, are not necessarily pathognomonic. So it's tough. And then there's also the social component. You don't want to accuse parents of abusing their children. So it's a difficult situation. As far as the workup, as far as history, you want to look for injuries that are out of proportion or inconsistent with the mechanism. Ask parents about, the timing, the mechanism. What did you guys do afterwards? Was there a delay in seeking care? Look for discrepancies between providers' stories, and look for evidence of past injury. On exam, you want to look for bruising. Typically, it's patterned, so it'll look like a belt, or it'll look like a grab of a hand, and they tend to be on non-bony areas. So where their bony prominences are, that's where kids tend to fall and get bruises accidentally, but non-accidentally, and that's sort of accidentally shown in this first image. Non-accidentally, there are non-bony prominences. You also want to look for burns. They tend to be symmetric without a splash, because most skull burns, kids are bringing hot fluid down on themselves, and there's a splash injury. When they're being submerged under hot water, they tend to have a sparing of their buttocks as it's pressed against the bottom of a tub, for example. And then in their skin folds, they have sparing as well. Other injuries that can be seen, fractures and posterior rib fractures are very common from grabbing a baby where the parent's fingers are around the back. You want to look for fractures of different ages as well. A kid may come in with a big femur fracture, but he may have a healing clavicular fracture. That's a big tip-off. A head injury, bilateral injuries are a cause for concern. Nonlinear skull fractures are a cause for concern. That takes a lot of force. Retinal hemorrhages are a big deal. Most of the kids with head trauma that we suspect NAT, we have an ophthalmologist take a look at their retina, and they see retinal hemorrhages from either the blunt force or from shaking. And then in the abdomen, duodenal injuries and liver injuries are the most common. So the NAT workup is, if you suspect it, is getting a CT of the head. I would certainly advocate for that. And then an ophtho exam, a skeletal survey, looking at all the bones of the body, and then labs, screening for liver, pancreas injury. We get D-dimers. There's a lot of literature in the pediatric population that D-dimer is a sensitive measure for traumatic brain injury. So we look at that. You want to get a CBC, not only to rule out hemorrhage, but also to look for evidence of chronic anemias. A lot of these kids are neglected and malnourished. You want to look for coags, as you may be thinking NAT, but maybe they have an underlying coagulopathy, and it's possible that this was accidental. You want to engage social work and also a child protective team that's typically a physician and that works very closely with child protective services. So in summary, for children, the primary and secondary surveys are also the systematic evaluation that we use. The primary survey should be age appropriate to account for the differences. CT-associated radiation is not good, and it is carries significant risk in children. Fortunately, clinically significant TBI can be effectively screened by those PECARN criteria, and again, I would encourage everybody to use that PECARN online tool, or at least take a look at it. And low-risk children who are demonstrated to be so by the PECARN criteria can be observed safely. A large percentage of kids can be cleared clinically as long as that's based on nexus criteria. And abdominal injury is primarily screened for by labs and exam, and kids don't need to be universally scanned. Like adults, most solid organ injuries can be observed. And then keep an eye out for NAT, always have it in the back of your head, and engage your social workers to help with that. These are my two favorite pediatric patients, and I'm glad to take any questions you guys might have.